Dr. Di Lawrence, Chief Medical Officer at Sarlan and clinician paediatrician. This next step in our maturity of our true co-design with our patients will take us to the next level in a really equal partnership with our patients, as opposed to the old-fashioned model of doctor-patient, clinician-patient relationship. It really is taking us into a true realm of contemporary practice and will absolutely improve the quality of life of our patients as they go through their healthcare journey with us. My advice to our clinicians who are trying to really implement this into their daily practice, whether they be our trainee medical officers, our nurses, midwives, allied health professionals, would be to really just take that little bit of extra time to truly listen to our patients, to ensure that they've really heard what does matter to them, so that they feel that we've heard them and we can walk with them to try and implement their goals of care. We know that if we do this and they feel heard, that our patients and our consumers will experience an improved quality of life, even if they have a healthcare issue that we can't ultimately cure them of.
Understanding what matters to you from the patient's perspective requires understanding something about the patient. So I start by learning who they are, where they come from, what their background is, what's important to them in their life. And that eventually will get me to what's important to them in the context of their healthcare plan. But the first step, and probably the most important one, is seeing the patient as a person with their own priorities, life choices, context within which they live, and that will inform ultimately the specific question of what matters to them during their hospital admission.
I work in Aboriginal health and I'm working in a primary care clinic, and community members who come there expect that there is a way of interacting, and one expectation is that we're going to listen to the story. And I tend not to ask a lot of questions. I do a lot of listening, and in that listening it comes out as to what really matters to them. And it could be more than one thing, obviously. And often what I say, and particularly this is to young doctors or even medical students who come through us, is firstly, not to be afraid and not to think it's some strange phenomenon that's beyond understanding. That if you actually look, and it sounds really like a cliche, as to how you would like to be treated if you went into a hospital, you know, how would you like people to listen to you, what would you like, then it's not difficult to start thinking about talking in that particular way to patients, even though all of our training, and particularly as doctors, is all about eliciting a history, you know, from the person, and then doing an examination and then finding out, you know, coming up with an idea as to what's going on and then trying to help. Is having that time and that patience just to listen a little bit more beyond the set of questions that you might have that you think is important to figure out what's going on with the person, because it's a very limited finding out what's happening with that person. It's not really asking what matters, and they're two different things.
I think it's really important never to assume that cognitive impairment might impede that conversation. I think it's always important to try and have those conversations with the individual, and where there are barriers, whether that's for cognitive reasons or language barriers, then involve other people who are important people in that person's life, whether that be a carer, a loved one, a substitute decision maker. Having those conversations can be facilitated by using a broader audience.
One of the things that is very important in our work is to listen carefully to what people are saying to us and try and craft solutions for their particular problems. And we undertook to do some research to try and improve the outcomes of people with a frozen shoulder, and we undertook a randomised trial with a new treatment based on some of our earlier research. Interestingly, frozen shoulder treatments have often been directed at the restriction that occurs with frozen shoulder. Frozen shoulder means people can't move their shoulder, and one of the important things that are always emphasised with managing frozen shoulder is getting the shoulder moving. As we spoke and listened to our patients, it became very clear to us that for them, that was not the biggest issue. The biggest issue was their pain. So our research work focused more strongly on the pain of frozen shoulder, and we discovered that if we managed the pain better, that in fact the outcomes for the patients improved rapidly, and in fact their range of movement improved very quickly. So it was a matter of emphasis, moving from trying to get the shoulder moving to managing the pain better. And we learnt that specifically from listening carefully to the patients.
I'd been involved with Salem for quite a while as a patient and family rep. Use the things about active listening to be able to use summarising skills, those sorts of things, and to pick up on how are you feeling, and therefore working on a real partnership. Perhaps if I'd even leave you with one little story. There's a story about a river. A person comes to a river and very narrow and can't get across, but sees someone across the other side of the road. And so they yell to the other person, "How do I get to the other side?" And the other person scratches their head and says, "You're already there." And that's a very poor dad story, but it really tells us the story about if you really want to understand where people are coming from, you've got to actually work out where they are.